And the risk factors for fibroids. So we know that fibroids can occur, it's most common between the ages of 35 to 45 years. And however, this can also occur late teenage years. And risk factors can include early menstruation, early periods, and also late menopause. Diet rich in meat, ham, beef. Obesity is also a risk factor, and also a family history of fibroids, which is seen in 40% of cases. Also, no history of pregnancy, and also women with just one child, and also seen with ladies who have high blood pressure and also diabetes. So in terms of the prevalence, this is important for us. And there are numerous studies being done now because since fibroids have become very prevalent now, so studies show that Black women have a higher incidence of fibroids. And one study found that 35.7% of Black women had fibroids diagnosed by ultrasounds compared to 10.7% of white women and 21.8% seen in Asian women. A study published in Fertility and Sterility stated that a cumulative incidence of fibroids by the age of 50 years is over 80% of Black women. So very high numbers for Black women. So that's threefold when compared to white women. And in terms of the symptoms, so greater than 50% of women are asymptomatic, which means no symptoms. And this is normally seen when the fibroids are a size of less than 4 centimeters, or the uterus or the womb size is less than 12 centimeters. Patients or ladies complain about pain, especially during their periods or menstrual cycle. They have pelvic pains and also back pains. And sometimes these pains may be associated with radiating pain to the legs or the thighs. In our culture, we know that as soon as we see someone with a big or a high tummy, we assume that they're pregnant. But some ladies with high tummies, they do suffer with fibroids. And in terms of anemia is another sign of having fibroids, where patients would present symptomatic with dizziness, fainting episodes, feeling fatigued, they're very tired, unable to go to work. So it affects the patient's or the lady's lifestyle. In terms of urinary symptoms, increased frequency and urgency, and this can then impact on their bladder care and also increase the risk of having bladder infections or urinary tract infections. Ladies can present, especially to the emergency department, with heavy bleeding, and this can be described as gush of blood, increased change in the number of the pads, and also passing large clots, and also prolonged menstrual cycle, and infertility. To understand fibroids and how they affect us, we need to understand how fibroids are classified. So there are different types of fibroids, and where they are located in the womb is very different as well. So you have fibroids located within the body of the uterus, and these include your subserosal fibroids, which are on the outer part of the womb. You have your submucosal fibroids, which are on the inner part of the womb. And these fibroids, the submucosal ones, can cause distortion of the uterine cavity. And intramural fibroids or intramural fibroids, these are fibroids within the muscle layer of the uterus. And these can present with pain and heavy bleeding during your menstrual cycle. Pedunculated fibroids is another form. And as you can see in the image there, the top fibroid protruding at the top, that's a pedunculated fibroid. And you can have cervical fibroids as well. That is at the neck of the womb or is at the cervix. And interestingly enough, cervical fibroids can present with heavy bleeding, intermittent bleeding within the months or within your menstrual cycle, and even bleeding after sexual intercourse because it protrudes or drops into the vagina. And now we go to a very interesting topic about fibroids and fertility and how fibroids can affect fertility in women. So the effects of fibroids on fertility. So fibroids have a significant impact on the reproductive health, being linked to subfertility and early pregnancy loss, unfortunately. We know that 5 to 10% of women facing infertility problems have uterine fibroids, And it also depends on the size of the fibroids and also where the fibroids are located. And this may create problems in fertility as well as within the pregnancy. So how does fibroids affect fertility? So the fallopian tubes can be blocked, and which makes it challenging or nearly impossible for a fertilized egg to implant within the womb. It also changes the size of the cervix, also the size of the uterus. And if the fibroids is within the cervix, then this can affect the number of sperms that can enter the womb. And also submucosal fibroids, which are the fibroids within the endometrium or within the womb cavity. These also significantly decrease implantation of the embryo of the baby, and this causes distortion of the womb. As seen in this diagram, there's a huge submucosal fibroid that is actually dropped within the uterine cavity, and there's a cervical fibroid protruding from the neck of the womb. So therefore, sperms may be unable to get inside of the cavity. And if few sperms get in and if few sperms meet the egg, then what about implantation with this big submucosal fibroid within the cavity? So in this diagram, I wanted to show how a normal womb or a normal uterus looks like. So there's no fibroids, there's no thickening of the endometrial lining, there's a nice uterine cavity, right, for implantation to occur. However, with the imaging adjacent to that, it shows submucosal fibroids distorting the uterine cavity as well as falling inside of the womb, the lining of the womb. And then the bottom picture shows where fibroid is just pressing exactly where the tubes meet the fundus. So therefore, for the egg to travel inside of the womb, that causes blockage. Therefore, infertility issues or fertility issues. So fibroids and pregnancy. So this slide explains what we know about fibroids in pregnancy. And to be quite honest, fibroids can cause no symptoms in some women who are pregnant, but with women who are pregnant with fibroids, some of them, the fibroids can grow in pregnancy, and this can be large fibroids. There was a study done in the UK that showed 71.4% of fibroids grew in the first and second trimester, whereas in the third trimester, 66.7% grew between the second and third trimester. So fibroids during pregnancy are more likely to be encountered in patients who are over 35 years old, if it's their first pregnancy for ladies, or if they are Caribbean or African descent. And as we know, fibroids can increase the risk of pregnancy complications. So I wanted to just separate the trimesters. And in terms of first trimester, we know that in the first trimester, it's 0 to 12 weeks and 6 days. And with the first trimester, you can have increase in the size of the fibroid. You can have what is called redegeneration of the fibroids. This is a painful episode in pregnancy, and it can be very severe in some women where they will present with pain and tenderness at the fibroids point when they are pregnant. And these ladies may need to be admitted for pain medication, for support. So conservative management. So conservative management, and also miscarriage is another complication in the first trimester. So this was a recent case of mine that occurred on the 27th of May while I was covering the gynae acute treatment unit. So in the hospital I work with, the emergency department is downstairs and the gynae acute assessment is on the second floor. So at around 10 p.m., I got a call from the emergency doctor saying that there is a lady, Asian descent. She's 24 years old, first pregnancy. She's known to have 18 centimeters size fibroids on her last ultrasound. And she presented with bleeding and pain. And in terms of a history, she changed about 3 soap pads in the last 2 hours, but now gushing blood in the ED department. This was the 3rd time presenting to the emergency department. The previous times was just for pain and mild spotting, and she was sent home and didn't need any admissions. So I accepted her to the gynae assessment unit, and present with her was her partner, and she was actively bleeding. I examined her in the presence of one of the specialist nurses, because we have specialist gynae nurses that work on nights with us. And when I examined her, there was lots of blood coming from the neck of the womb. The neck of the womb, the cervix was open, and I could see where the baby was about to be expelled. Of note, her blood pressure was dropping, her heart rate was increasing, and she then became very pale. So therefore, she went into shock, hypervolemic shock we normally see. So the anesthetic doctors, the doctors who normally put patients to sleep, were called in. We took her to theater, consented her to theater. We had to get 6 units of blood from the blood bank, right? And in theater, I had to do what is called a suction evacuation of the remaining products, because the placenta would still be inside. But however, when I examined her, and she was asleep when I examined her. So next slide, Clarice. So when I examined her, thank you. So when I examined her, I could feel within the womb, there was a large fibroid protruding. So I couldn't get in my instruments to perform the suction evacuation. So what I did, I then had to insert just 4 steps and try to remove the placenta. In total, she lost 2,000 mils of blood, and she received blood transfusion in theater and on the ward. This patient actually stayed in hospital for 7 days, unfortunately, because to manage the pain was a lot, in terms of she needed a lot of pain medication. The fibroids were big. She looked like if she was like full-term pregnant, because the 18 centimeter size fibroids was still big, and it was very tender. And during that course of time, she had to receive antibiotics as well, because she was spiking temperatures. So this was a very awful experience for her and her partner. And so we had to debrief them to explain what happened, what was the cause of the miscarriage. And obviously it was the fibroids, unfortunately, because of the size of the fibroid, and because inside of the uterine cavity, there was a huge fibroid. So we then had to refer her to the gynae clinic as well. And also counseling was offered, which is very important to both mom and the partner. In terms of the second trimester, the effects of fibroids include increase in abdominal pains, and also red degeneration, as mentioned in the first trimester, increase in the size of the womb. So if you like 18 weeks pregnant, some persons may think that you look like if you like 6 months, you look like if you're 8 months pregnant or 9 months pregnant. So patients also present with bladder symptoms or pressure symptoms. So they are unable to pass urine because the fibroid is pressing on their bladder, and also increased risk of constipation in the pregnancy. So the third trimester, a very important part in terms of the effects of fibroids. So you can have malpresentation of baby, and malpresentation means that because the fibroids is distorting the uterine cavity, baby head is not being able to go down into the pelvis and sit in that perfect position. So therefore, baby bum may be presenting, or legs presenting, or baby may be diagonal or transverse lie, or what we call oblique lie in the womb, right? Also, there's a risk of preterm labor. Some ladies can go into labor before 37 weeks. And there's also non-engagement of the baby, where baby can't go further down into the pelvis, can't go further down into the vagina. And also postpartum hemorrhage, which means severe heavy bleeding. And finally, difficult cesarean section. And this increases 48-fold in ladies with fibroids, depending on the size, one, and depending if the fibroids is located close to the cervix or in the lower segments. And this next picture just shows in terms of the malposition. So there's a fibroid in the back of the baby. And at this stage, the baby head is supposed to be facing down, but however, it's the baby legs and the baby bottom. So this can also occur because of fibroids in the third trimester. So this case was actually recent, last week, while I was covering delivery suite or the labor ward on the 29th of June. And there was a 33-year-old. She was Black, from Nigeria. She was in labor at 39 weeks. This was her first baby, so risk factor. She was known to have uterine fibroids, honestly, very small compared to large fibroids that we normally see. So 5 centimeters by 6 centimeters in size. And she was 5 centimeters dilated for like the past 6 hours. But when I came onto the shift, I realized that the baby wasn't happy. So she had an abnormal baby stress in labor. And when I examined her, she was still 5 centimeters and the baby's head was very high. So I knew to myself that, oh, she cannot deliver vaginally because there's something going on within that's causing baby not to be descending or going down further into the pelvis. So the plan at that time was for emergency cesarean section. She was anemic. Her blood count was 94. And in theater, everything went well. And I'm sorry for the pictures, but this is a picture when I closed in terms of doing the cesarean section. And there was 2 large fibroids right above that area where I cut to deliver baby. But thankfully, her blood loss was just 500 mils, which is very normal for a cesarean section. And both mom and baby went home the following day. Day 1 post-surgery. So sometimes we forget to discuss what happens after baby is delivered, after mom goes home with baby. So the postpartum period, this is within the 6 months after delivering. And unfortunately, some moms with fibroids, they can represent with heavy bleeding, which is called secondary postpartum hemorrhage. And also another thing that can occur is subinvolution, where the uterus fails to return to its normal size after pregnancy or childbirth. So say, for instance, before you were pregnant, you had a flat tummy, but when you got pregnant, your fibroids grew and they got bigger in your pregnancy, you delivered baby, and then you expect for your tummy to go, or for your uterus to go back to the same size. But no, the uterus can sometimes stay big. So subinvolution. And some moms can represent with infection or sepsis, and that's rare. When we have pregnant ladies with fibroids, we normally tend to want to know, is this fibroid uncomplicated or complicated? So very important. And for uncomplicated fibroids, there's no treatment is required. So usual antenatal care and usual antenatal visits. But however, for all cases, the patients must be assessed at 38 weeks to discuss method of delivery, whether vaginal versus cesarean section. In complicated ladies, these ladies tend to be ladies with large fibroids. They normally have to be readmitted to hospital during their pregnancy because of pain or the red degeneration syndrome of the fibroids. And they will need pain, rest, and they will need pain medication, rest, and also hydration. And we also have to think about optimizing their blood counts because they can present anemic or low blood counts. So we normally have to think about, do we give them iron tablets? If they have been on iron tablets, do we think about giving them iron infusion, which is very common for us to give iron infusion? And also, do they need blood transfusion? So I once had a lady who I saw in clinic and her blood count was like 60, which is very, very low, very anemic. So we had to admit her, and she was around 35 weeks. We had to admit her for blood transfusion. She got 2 units to optimize her because when it comes to delivery, she would need that supply. And in terms of management of labor and delivery, so it also depends on where the fibroids are situated. So if the fibroids are above the presenting part, so in the first diagram, you see where the fibroid is in the lower part of the womb, baby is still high up and baby hasn't descended. So in the second diagram though, the fibroid is high up above in the uterus and the baby is well deep down in the pelvis, ready for vaginal delivery. So normally these patients will have vaginal delivery. And then if the fibroids are situated below the presenting part, very, very low and blocking baby's pathway from baby head entering into the pelvis, then you have to discuss with the patient the options that honestly, you're most likely to have a planned cesarean section. And we have to optimize you, making sure that your blood count is normal, or making sure that we have blood products. So you group and cross match them if they have low blood counts. In the UK, we also use what is called cell salvage. So while doing the cesarean section, any blood that is lost from them is passed through a machine and then goes back to them. So that's cell salvage, and that works really well. So I'll pause here because that was for fibroids and pregnancy. Any questions? Okay.
I would ask, why the prevalence among Black women? Is there a known factor?
So I was reading it, and it's actually multifactorial. They were saying that it has to do with genetics, but it's not just one gene, it's multiple genes seen in the Black community. So, but however, it's still an unknown cause as to why. But because of our genetic makeup, that's why it affects us more than white women and also Asian women, unfortunately.
Okay, thank you.
You're welcome.
Do you all advise removal of the fibroid before pregnancy?
It all depends. To be quite honest, sometimes you can do watchful waiting because it depends on where the fibroid is located. So say for instance, if a lady comes to us in clinic or to the fertility clinic or anywhere in gynae, and she has fibroids located on the outside of the womb, which we call a subserosal fibroid, we wouldn't advise removing the fibroid because those fibroids are normally asymptomatic. They're not inside of the womb. They normally wouldn't cause any symptoms in pregnancy. So we will say no to that. But however, if she has multiple fibroids, different types, and the sizes of the fibroids are like more than 8 centimeters, and in the UK, what we normally do in the outpatient clinic, we could do what is called a hysteroscopy, sorry. And that's where we pass a camera inside of the womb and we look at the endometrial lining and see if any fibroids are located within the womb cavity. If there are fibroids within the womb cavity, then we can remove it, not by major surgery, but just by doing a hysteroscopic resection of the fibroids then in the outpatient department. So it depends on the size and where they are located.
Thank you.
Dr. Armstrong, we also have one question in the chat, a very interesting one from Crystal Chapman. She was asking, in instances where you do a C-section, do you remove the fibroid as part of that surgery?
Very important question. And to be quite honest, we are told not to because performing a myomectomy, which is removing the fibroid at cesarean section, can cause more bleeding and lead to more complications and hysterectomy. But I have been in cases in Tobago as well, doing a planned cesarean section, known to have uterine fibroids, and a fibroid was presenting at the lower segment where I had to cut the uterus and I had to just quickly remove the fibroid, quickly deliver baby, quickly clamp that area that would be bleeding. So we don't intend to remove the fibroids at cesarean section because it's unsafe due to the risk of hemorrhaging, but sometimes in some cases we have to just to get to baby.
Thank you, Dr. Armstrong. Any other questions, ladies, at this point, or can we continue?
Just one
Okay.
question.
Go ahead.
And maybe a continuation of the question that was previously asked, not the one that was in the chat. But are there scenarios where you will not recommend that a woman gets pregnant if she has fibroids? Like are there certain sizes that, because fibroids tend to increase in size when they during the pregnancy. So if you're starting off at, or if it's 20 fibroids and size is 5 centimeters and stuff like that, will you suggest that that woman, hey, you need to do remedial action first before you even consider pregnancy, given all these things that you spoke about?
So thank you for that question. So I'm a firm believer of optimization. And that's why I love the fertility aspect in gynecology, to be quite honest. Because to answer that question, you have to optimize the patient. You have to do an ultrasound, right? You have to know where these fibroids are located. And as you said, the sizes of the fibroids, but where each fibroid is located. In the UK, we actually do MRI. So we actually do a further investigation to get proper imaging to know how in depth or how far the fibroid is entering the uterine cavity. So we'll do that. We'll also want to do a laparoscopy or a hysterosalpingogram. So big words meaning we want to see if the tubes are patent. right? So we want to know, we want to optimize the patient. We want to know your history with fibroids. We want to know if you had menorrhagia, which is a heavy bleeding, painful fibroids. We want to know everything and your blood counts. So we would say, okay, let's take a total view, a total wholesome picture of you. We want to know your fibroids location. We want to know if there's a chance of you getting pregnant. So that is why we have to do all these investigations first. So I wouldn't say no, not to get pregnant. I would say yes, you have to see a gynecologist. You have to have a discussion. And now it's 2025. So I think every woman should have a gynecologist where they could just sit down and chat, especially if you have uterine fibroids or endometriosis or adenomyosis. You should have a gynecologist. And we have two doctors, Dr. Wheeler and Dr. Winchester here. So yeah. Honest, I saw a question.
Yes. So I was just about to raise it as it relates to less invasive procedures and treating with fibroids naturally.
Okay, so I'll start with the less invasive. So my next few slides at the end of the presentation, they have the less invasive procedures. So I will talk more about that. And in terms of naturally, I know that we have in a presentation next week with nutrition.
Yeah.
So I know
Yes.
that there's a lot of things going on TikTok and in Google searches about what could shrink fibroids. But at the same time, I'm very mindful because what could shrink fibroids naturally sometimes can have an effect on the endometrial lining of the womb. Is it going to give endometrial cancer? So it's a balance. And that's not my area of expertise. So I don't really want to go into that.
Yes. So let me see who was the person that asked the question. So to Mac, based on the name I'm seeing here, as it relates to shrinking fibroids naturally, because we appreciate that the thought of major surgery or surgery on a whole can be daunting, right? And so treating with fibroids naturally, I'm not sure if you remember Dr. Armstrong sharing that in response to a question in terms of the gene, right? Our genes as women of Afro descent, Caribbean women, Black women, fibroids affects us differently. It affects everyone differently. And so treating with fibroids naturally also will not have the approach will not be the same for everyone. Through the years of my living this experience and, just doing the research and engaging with different platforms, I have seen persons share and talk about their experiences or their experience in living a healthier lifestyle, being more organic with the food that they eat, the choices that they make. But again, it's a very individualized journey, and it also requires peak, and when I say peak discipline, right? Because there are just a number of things that impact the body. But we'll definitely get into this next week, right? Dr. Armstrong spoke about estrogen dominance, which is the female hormone. Fibroids being linked to that. So of course, there's that hormonal linkage. And so it's a much broader picture. There was another question, Dr. Armstrong, that related to decreasing estrogen levels. How can that be done? And then we take the final question that came in so that we could move on with the presentation on whether fibroids can cause ectopic pregnancy.
Oh, you're welcome, Mac. You're welcome.
That's what we're here for.
Yeah. Oh, okay. So in terms of
decreasing
estrogen
our
level, if we can decrease our
right?
estrogen level, the thing is that we are in our reproductive age. So we are supposed to produce estrogen. So estrogen is actually good for heart functioning, cardiac functioning. So trying to fully decrease it will have risk on our cardiovascular system, which would therefore increase the risk of heart attacks and other cardiac conditions. However, to counteract or to make a more balanced environment, we can introduce progesterone. And that's why one of the treatments of fibroid in terms of the medical management is actually putting in a Mirena coil into the womb. But however, that acts as a contraceptive as well, so you wouldn't get pregnant, right? There's also other medications that I will come to further in the presentation that actually stop estrogen from being produced. And those are called the gonadotrophin-releasing hormones, which we have it in injections and now in the UK as a tablet form. However, with that, you don't do prolonged taking of it just because lack of estrogen causes very thin, frail bones, causes fractures very easily, and that is called osteoporosis. So in everything in medicine, you have to find a balance. So if you're stopping the estrogen production, you have to think about stopping it for a very short time, maybe 1 year, but then we all need estrogen in our reproductive age group because estrogen actually helps with vaginal secretions. So lack of estrogen will cause painful or dry sexual intercourse. So we need estrogen to some point. But good question.
And the last question before you move on was about fibroids causing ectopic pregnancies.
It depends because ectopic pregnancies, one of the most common risk factors for ectopic pregnancies is infection or STIs, and that has to do with scarring of the tube. So if there's a blockage in the tube, then that causes ectopic pregnancy. So maybe if you have a fibroid blocking the tube, then that could cause the pregnancy to just stay in the tube. So yes, that can be a cause of ectopic pregnancy, thinking about it. So thank you, Shania.
All right.
So this is the latter part of the presentation, and this deals with management of fibroids in general. So in terms of management, so conservative, we always start with conservative management, especially with ladies with small fibroids. And sometimes fibroids can present as an incidental finding. Like say, for instance, you're not seeing your period for 3 months, you go by a gynecologist, he does an ultrasound, or he or she does an ultrasound on you, and then you see 2 small fibroids, like subserosal fibroids. There's nothing to do. Watchful waiting, I would recommend. But think about diets. So increase your green leafy vegetables, reduce your red meats in your diet as well. And also exercise plays an important role. And then for the medications part of things, and I know some patients, when they come to doctors or gynecologists, they feel not being listened to, because I think that some patients want surgery, but surgery should always be the last resort. And that's what I was taught, mainly because surgery has its complications. So we first start off with medications. Honestly, we first start off with medications. And if the patient is anemic, we want to give them iron tablets, right? And we have to ask the question, do you want to conceive now? Or if you don't want to conceive now, we could think about giving you oral contraceptive pills. So both estrogen and progesterone, or just the only progesterone pill, right? And I mentioned when we were having the questions and answers about the gonadotrophin releasing hormone agonists. So in the UK, we have Prostap injections. And in Trinidad and Tobago, we have Zoladex. Imagine today, I couldn't remember Zoladex. I had to actually Google it when I was like, oh my gosh, I haven't used Zoladex in a while. But these injections, pretty good. So these are used to shrink the fibroids, right? You have your 1 month injection and you have your every 3 months injection. And the Zoladex can be used to actually shrink your fibroids in preparation for surgery, in preparation for myomectomy. So that actually helps you to reduce your blood loss at surgery. However, with everything in medicine, there are side effects. And with gonadotrophin releasing hormone, the side effect is osteoporosis, as mentioned before. So in the UK, if a woman is on Prostap injection, which is similar to Zoladex, we will normally send them for a bone scan after 1 year or after 18 months, just to ensure that the medication is not affecting their bone density. And some women actually want to stay on the Zoladex for a very long time, or the Prostap injection for a very long time. So we have to counsel them. I had this woman in clinic, and I had to really counsel her because she was adamant. Doc, you're not stopping it. I'm still going to go to my GP. I'm not coming off of it. And I had to actually discuss it with her and say, this is your risk factor for osteoporosis, brittle bones. You could break your hand, you could break your legs. But however, what we can do is we could write to your general practice doctor, your GP, to have them doing yearly or annually bone scans of you. Then in terms of your mefenamic acid and your tranexamic acid, so these medications, some could describe them as the non-steroidal medications, and these medications help with pain and also reducing the blood. right? Mefenamic acid. This medication is taken at the first day of your period. I started taking mefenamic acid, and it works. It works. There's also the Mirena coil, which is the progesterone only coil. It doesn't work for all uterine fibroids, because if the fibroids are within the endometrial cavity, then you can't put in a Mirena, or you may have to have the Mirena coil inserted hysteroscopy with the camera test, right? But Mirena is an option if your fibroids are located outside of the womb, but it is a form of contraception. This is a new drug in the UK. It's called Ryeqo, right? And it's a tablet to be taken daily. And it is started from the first 5 days of your period, and you can take it for a year or more. The thing with Ryeqo is that it also has to do with your gonadotrophin agonist, as well as it has estrogen and progesterone in it. I had a lady that I saw in the community, because in Leeds, we actually go to the community and we have like a community gynecology office as well, because patients who can't get into the hospital, we actually formed a gynae clinic outside in the community. So I saw a lady who was trying to get into the clinic, and for the past 6 months, she couldn't get in. Her GP wrote to us, and we told her GP, her general practitioner doctor, to put her on Ryeqo tablets. She had fibroids of more than 10 centimeters, so large fibroids. So when she finally saw me at the first visit, she was happy. She was like, "Doctor, I have something to tell you." I was like, "What?" I was like, "I'm happy. I don't want surgery. I want to be discharged." I was like, "What do you mean?" I was like, "Well, I started Ryeqo tablets, and I have like, my periods are very light. I have no pain anymore. I'm a new woman." And so that is a response that we're getting from Ryeqo. And that same patient that I mentioned in the first case with the miscarriage in the first trimester, we did send her home on Ryeqo tablets because it works. But for her, she would need like a long-term plan. What do we do with her fibroids? And also progesterone only tablets. And these tablets can be used like if you come into the hospital, heavy bleeding in the emergency department, admitted to the gynae ward, we could give you norethindrone, we could give you Provera, and there's an injection form of Depo-Provera as well. So these are the medications. And these are the less invasive procedures that we can do. And Sonata has been new to Leeds in the past 18 months. We do it in the outpatient unit. And this ultrasound device is inserted into the womb using a radio frequency energy to reduce the size of the fibroids. So this normally targets the submucosal fibroids, the fibroids that are within the cavity, and it's really good. So patients actually go home the same day. It's an outpatient clinic procedure. They go home the same day. They are awake, having a procedure done. And we may give them like ibuprofen to be taken 1 hour before. And while having a procedure, if they have any discomfort, we have gas and air in the clinics, and we have what is called pen tracks, which is like a pen-like whistle-like structure that they can actually breathe in and out, and that gives them analgesia or pain medication and works quite well. I'm not sure if my video will play for the next slide, but however, I wanted to show how hysteroscopy resection of fibroids is done. I actually had a case, next slide, Corey, sorry. I actually had a case yesterday in theater. Yesterday was a gynae theater list, and I had a case with she was actually a white woman. She has 2 children, 5 and 6 years old, and she has a fibroid in her cervix protruding in her vagina. And well, because that fibroid was protruding, we had to remove that fibroid, and then we did a hysteroscopy. I did a hysteroscopy, which is a camera test that goes inside into the womb, and I looked at all the corners of the lining of a cavity, and there was a tiny subserosal fibroid. So we just easily resected that fibroid then and then vaginally, not cutting her, not opening her, but then and then vaginally. And she was sent home the same day in the evening, 3 hours after the procedure. And then we have uterine artery embolization, where we know that if we insert certain medication into the uterine artery, it stops the growth of fibroids, and the fibroids then shrink. This is done by interventional radiologists, and I think Trinidad does it. But with uterine embolization, you're unable to get pregnant after that. So more likely for women who have finished conceived or have completed their family. and this, so surgery, so myomectomy versus hysterectomy. So just to answer one of the young ladies' question in terms of if they should remove all their fibroids. So if your fibroids are symptomatic, meaning causing symptoms and you want to have a baby, yes, you should think about having a myomectomy after speaking with a gynecologist. And with myomectomy, it means removal of the fibroids itself. So leaving the womb intact and removing the fibroids. Things to know before you plan to have a myomectomy, your gynecologist or the hospital will have to optimize you, make sure that you have a good supply of blood, you're not anemic, right? So taking iron tablets if you're anemic, making sure sometimes you can have the gonadotropin and releasing hormone analog injection, the Zoladex, to help to shrink the fibroids for your myomectomy case, right? And that helps, and you could have your myomectomy. As in medicine, we will normally go through the consent forms. Heavy bleeding is a factor, is a risk factor, as well as injury to surrounding structures. But we do myomectomies. Also, hysterectomy is seen in women who have completed their family, maybe in their 40s, they're very far off from menopause, and they said, look, doc, every 3 weeks I'm in the hospital receiving blood transfusions. I am sick. I am tired. I have big fibroids. I have 3 little kids at home. I don't see myself having any more children. Yes, I want a hysterectomy. Major surgery as well. So it's very important to optimize you. And thank you. And we'll take more questions or discussions. Very happy to hear, or very happy for questions to be asked.
All right, so before we get into the questions, I've actually taken note of 3 in the chat. I just wanted to invite one of our, let me just ensure that she's on. I just wanted to invite Petal. Petal is a local mommy that I know who only found out she had fibroids when she got pregnant. And her experience really fits the bill that you've explained, Dr. Armstrong, of just really being uncomplicated, right? And because, of course, when we have presentations like these, and just generally because of lack of information and misinformation in this space, there's a lot of fear. And the person's often thinking of the fertility challenges and that pregnancy is not possible, or if I do get pregnant, it would be the worst experience. And so we often try to ensure that we strike a balance in everything that we do and share all experiences, right? We're on this journey together, but by the grace of God, your journey does not have to be a difficult one. And even if it is a difficult one, we are here to provide as much information for you as possible so that you are empowered and you are encouraged and you have some hope. So Petal, you could just share from your heart how, what the experience was like, when you got pregnant, and then of course you did the ultrasound, and what you were told, and then what your experience was.
Good afternoon, everyone. Everyone hearing me?
Yeah.
Right. So I got married. Let me give you a little history. Got married in 2014. And by January 2015, I found out I was pregnant. Went to do ultrasounds and stuff like that, excited for my first child. And in the ultrasound visit, or at the ultrasound visit, doing the scan, and here I'm hearing you have fibroids. And I think at that point in time, I somewhat froze because I was not very knowledgeable about fibroids, but fibroids just sounded like a bad thing. And at the end of the scan, oh Jesus, I just forgot the name of the profession that does the scan, but the individual, the sonographer, yes, was indicating to me that I had 3 fibroids. They were ranging from 1 centimeter to, I think, 2.5. And I was asking her, what are the pros and cons of these fibroids? She indicated that 1, I can lose my child, have a miscarriage. 2, the fibroids can grow in the period of the pregnancy, because with the hormones and stuff, they can get larger. And one thing she said, though, is that because of their location, it may not affect the pregnancy. So that's because they were outside of the uterus. But again, not being very knowledgeable, what I knew a lot about is, or what I knew about is that Corey's, my friend, had an organization. So when I got home, I called Corey's and I'm like, Corey's, what about this fibroids thing? Because I started panicking, and I was really taken aback. Corey's gave me some additional information, had me a little calmer. I reached out to some other cousins and stuff, well, family members, let me put it like that. And they were indicating to me, keep calm. You have a young one within you, don't stress yourself. And I went along trying to be as careful, trying to change my diet. Went to the ultrasound again. The good thing is that the fibroids did not increase by much. They never interfered with the child. I was able to bring forth the child. It's just that when I was 4 months, I started bleeding and again went into panic mode. I was like, oh my God, this fibroid is trying to take my child. And lo and behold, I went on bed rest and stuff like that. But thankfully, I was able to have my child, and I didn't just have 1, but I have 4 beautiful girls.
Beautiful.
Right? So again, yes, fibroids. I've heard so many stories on the other side of the spectrum where persons would have had terrible pregnancies and experiences. But one of the other things why I was so taken aback is that I never had issues with my periods. They were always on time, no heavy bleeding, even though heavy is relative, but it wasn't like anything to alarm me. So I was taken aback when I first heard of the fibroids. So that's my experience in a nutshell.
All right. Thank you so much, Petal, for just sharing and being so open and transparent. As I said, the reason behind inviting you this afternoon was to share a perspective, right? And a perspective that can serve as an encouragement. Because again, culturally, the information in this space, misinformation in this space, and just generally not having knowledge about the condition. Sometimes we definitely need to hear, a testimony to be encouraged. So thank you so much, Petal, for sharing. And, I think you even kind of touched on some of the facts that Dr. Armstrong shared in her presentation, right? Where persons can have fibroids and they are asymptomatic. So you've lived your entire life and have no clue. You have none whatsoever because you felt normal, and the Petal, I know, very slim, flat stomach, athlete, doing everything. So to be told, ma'am, I'm seeing some fibroids here, could have definitely been jarring. But thank you again for sharing a testimony. And for all the ladies online, regardless of where you are on your journey, we are really about empowering and encouraging, right? So we're going to go back into the questions now. And I will start with Dr. Armstrong, that there was a question asking what size is considered a small fibroid, right? So I'm going to give you 3 questions. The second is how soon after myomectomy to try for a pregnancy. And the one person also shared that they will be migrating soon, and so the treatments that you spoke about, where you are based in the UK, what may be the process to access treatments through the NHS, and then we will continue with some more questions. So size, what size is considered small? How soon after the myomectomy to try for a pregnancy, and the process to access treatments via the NHS in the UK.
So in terms of fibroids considering small, for me it would be like less than 5 centimeters, or like my presentation said, less than 4 centimeters. So those are really tiny fibroids, like around this size. So tiny, 4 centimeters, 5 centimeters. It's still small, but sometimes having multiple small fibroids, that's where the problem occurs. Yeah.
Okay, and based on the location, as you said, right?
Yeah. Mm-hmm.
All right.
In terms
How
of,
soon after myomectomy?
So you normally want to allow the uterus to heal, right?
Mm-hmm.
And I know that Dr. Wheeler is in the chat as well, so he will correct me if I'm wrong. Normally we tell patients 3 to 6 months not to get pregnant, to allow the area to heal, or even 1 year, all right? Depending on where we did the fibroid surgery on the uterus as well. Sometimes we have to, sometimes we tend not to, but we can go very close to breach the endometrium. So we wouldn't suggest pregnancy then, but you give yourself time to heal.
Okay. And I do know there was in a person that we supported, and when I say supported, right? So if you come to us as an organization, you've gotten a diagnosis and you're just looking for general information and support, that's what we do. And we're not medical, so we do not do official referrals for liability reasons. But of course, we have conversations. And this person actually had a myomectomy done. After, we spoke about all the options, what is best in terms of preserving the fertility, the health of the womb, etc. They opted to do the myomectomy and in Trinidad. And then I think like within a year and a half, she had twins. She conceived twins naturally. So I do know, even from past presentations that we've done, even with Dr. Duke, who's out there in Las Vegas, they often talk about myomectomies really kind of being the best options. It sounds scary, but it gets rid of the fibroids. You're able to preserve that space and have successful pregnancies after, right? Process to access treatments through NHS, and let me continue to go through the questions as I see them in the chat. So go ahead, Dr.
So
Armstrong.
anytime you move to the UK, one of the first steps is to actually get a GP. So you get registered with your general practitioner, and your GP is like you have multiple GPs in every area, every space in the UK. So once you have a GP, they will normally refer you to the clinics or to the gynae clinic at Leeds Teaching Hospital if you're in Leeds or if you're in Manchester, because it's the big hospitals, the big tertiary centers that will do like the sonatal treatments. Even the small district hospitals does hysteroscopy, because that's something in training that all of us are supposed to learn how to do as a gynecologist. We're supposed to do the hysteroscopy and camera tests. So you just go to your GP, register to your GP, and you have a conversation with them with the symptoms. If you're symptomatic, then they would try to get you into the gynecology department at the hospital, the gynecology clinic. So it can be simple, but I can tell you the waiting list to see the gynae doctors in large hospitals, very long.
All right. Thank you, Dr. Armstrong. Can you share with us, we're seeing here from A. Alexander, if your cycle has stopped with the fibroids, is there a treatment or medication that is prescribed then? Is just the fibroids known for stopping your cycle? Or is that leading more towards another issue of the uterus, right? Mm-hmm.
And that's what I was saying. Yeah, you have to have your gynae doctor. You have to find out why your period stopped. Is it hormonal? Do you have polycystic ovarian syndrome? Because the thing with gynae conditions is that they go together. So one of these days I'll ask Chris if she would allow me to speak about endometriosis, because I'm actually part of the
course.
trial study of endometriosis. And we know that with ladies with fibroids, they do have a higher risk of getting endometriosis as well, which is painful periods, similar to fibroids. And if you know that you're not seeing your period, do you have polycystic ovaries? Do you need an ultrasound to look at your ovaries, as well as taking a history to know, like, in terms of when did you like stop seeing your period regularly? You may want to do your hormonal blood test if you go to see a gynecologist, to know if you have the sort of 3 for polycystic ovarian syndrome. So you have to be worked up to know what stops your period, because anything could stop your period.
Right. So, Ms. Alexander, you'd probably have to seek a bit more information from your GP, not your GP, your gynae. And of course, we have a free clinic coming up on the 3rd of August. So you can look out for that information as well. All right. So is the Sonata treatment done in Trinidad? Are you aware?
I'm not sure. I'm not sure if it's done in Trinidad, but it would be a good service to introduce to Trinidad and Tobago. So maybe I need to put that on my vision board.
All right, and because you shared the information here, of course, for us here at Fibroid TT, we will be doing some research on it as well to see what's happening in this space. We know there are places that do the embolization, but in terms of the Sonata treatment, we definitely have to put our ears to the ground to see what's happening. What's the best option if a fibroid is located in the ovary? Can a fibroid be located in the ovary or on or around?
No, so that would be ovarian cyst. Yeah.
Okay.
So fibroids is located in the womb or in the uterus, but you'll have other gynecological conditions that is on your ovary. So you could have endometriomas, which is seen in ladies with endometriosis. So they will have like cystic, like chocolate cysts on their ovaries, or different other forms of cysts on their ovaries. So it wouldn't be fibroids on your ovaries. But however, there could be a pedunculated fibroid close to your ovary.
Close by, okay.
Yeah. Sorry, I just want to pause because Shania said that she had a myomectomy in 2021 and was helped by you, Corey, through Fibroids Awareness TT. And you answered all the questions and gave advice, and now she is pregnant with twins. So congratulations.
Thank you. Testimony. Yes, yes. These are the stories that we actually love to hear, right? It's this is truly a passion project and a labor of love. And I genuinely believe that, once you're obedient, God tell you to do something. Well, that's for me, it is to do it. And so we continue to support and provide the information and support. So I'm really happy. I saw the name and I was like, I remember this name when I saw you signed into the session this evening. So thanks for sharing that testimony. I'm seeing here Candace sharing that, she had fibroids when she was 16. She was told, right, when she was in Form 5, but she was not equipped with the knowledge and the information, right? So she didn't pay much attention because she did not know. And she's 34 now, and she has been trying. I'm thinking here now as it relates to pregnancy. The sentence isn't complete, but she's at the point of being ready to give up. What is the best advice to someone who wants kids but doesn't have the information on it? I would immediately say, don't give up. That's the first thing,
so
right?
But
Doctor, you could go ahead. Right, go ahead, Doc.
So honestly, I would say don't give up. Do not give up. You just you need to seek a gynecologist. You need to know, like,
where they
if
are.
your periods are regular, you need to know, because to get pregnant, I always say it's like an oven or like an oven, and that's what I was taught in medical school in Jamaica. To get pregnant, you need sperms, you need the ingredients like the sperm, you need an oven, like what could bake your cake. So you need that. So you need to know if your uterus have fibroids or whatever gynecological conditions. You need to know if your hormones as well is working well, right? So you need to just see a gynecologist. And the thing is, we're in 2025, guys, there's no need for you to give up. Ladies are having babies past 45. I wouldn't recommend that, but just saying that don't give up. Don't give up. There's lots of options out there. Just need to seek the right help. Go to a gynae doctor, have discussions, and to be honest, so your gynae doctor may then refer you to fertility specialists. And with fertility specialists, they will then do more tests right? So that is an option. Never give up. It's 2025, guys. Things are happening. There is more research being pumped into women's health. There's more research.
Thank you, Dr. Armstrong. Candice, you could definitely reach out for via the number, the WhatsApp number 3621807, so we could talk some more and also look out for the information on the free clinic, right? But I really want to reiterate what Dr. Armstrong shared in terms of giving up. You need to know the full picture. As I shared on all interviews that I did this past week, except the one today, fibroids are not a final sentence on fertility. They are not. You can have fibroids and still have a pregnancy, still have a successful pregnancy. The journey may just be a bit different, but it's not the end, right? Dr. Armstrong, as I don't want to keep us online too long. We have another question.
It's
I
okay.
understand that fibroids are only tested for cancer after surgery. How do you ascertain what surgery is best, laparoscopy, laparotomy, or the sonata? And isn't it better to just do the laparotomy in case they are cancerous? So you could remove all if there's more that went unnoticed. Oh, yeah, that's definitely a doc question.
My apologies for the very
That's a
lengthy
question.
question, but I have an
No
upcoming
problem.
surgery.
Right, no problem at all. You
Pardon
go
me, you have
right
a
ahead,
what, sorry?
sweetheart.
I
She
have
has
an
an upcoming
upcoming
surgery.
surgery.
Go ahead.
Oh, okay. All right. So thanks for the question. And to be quite honest, leiomyosarcoma, big word for fibroid cancer, is normally seen in 0.1% of the population. And for the cases that I've seen and I've witnessed, even in Tobago, is more likely to be in postmenopausal, believe it or not, or older ladies. And you are correct in terms of when you do a myomectomy, when you do a hysterectomy, we do anything that we remove from the body, we send it to the lab, the histology to test for cancer. We do that for everything, right? So yes, they would send it for testing, but I'm a strong believer that being young with fibroids, it's not going to be cancer. That's just me. And that's just the knowledge and the information that's out there. But that's a really good question, Kay.
Can I add something to that, please?
Oh.
You can, yeah, sure.
Concerning the different types of surgeries, because I am a Trinidadian, but I'm in Canada presently, and
Right.
the gynecologist is in Canada. So, the surgery that they booked for me, they wanted to do the one with the robots. These words are a bit difficult for me to pronounce.
Oh, robotic
Yes.
surgery. Yeah, we have that in
So,
Leeds, yeah.
so that's the one that I was scheduled to do. But last year, I had a friend who had the same problems as I do presently, and she was in Trinidad. And of course, they did a C-section. So I was assuming I was going to get a C-section as well. So this is the reason for my question. Now,
C-section for pregnancy?
No, the
no, this is
myomectomy. That's
the
what she means. That kind of cut.
myomectomy.
Yeah.
Yeah,
She
they
means
did
the
a
myomectomy cut.
yeah, they cut her rather than using the robot arms.
She means a myomectomy, doc.
Okay.
So, my question was, when they do the ones with the robots, is it that they just removing what they see? Because when they went in for her via the C-section cuts, there were more than what they saw on the imaging. So that's the reason for the question. Is it not just better to do that C-section cut so that when you go in, you get everything out?
But it's the same thing with the robotic surgery, because I've been involved in robotic surgery, but robotic gynecology surgery. And you see the same thing. So it's a laparoscopy, it's keyhole surgery, but via the robots when you put the ports in. So when you cut, yes, you see in the entire uterus, yes, you'll be able to remove. And that is what we started doing a very long time ago. But now there are more advances in technology and now more places internationally are doing robotic surgery, mainly because of one cosmesis, right? But however, the robotic surgery still will see a fibroid because we're using a camera. We have 3 screens in theater. We're seeing everything, and we're able to, same dissection, same cutting, same removal of fibroid. We're seeing everything. But it depends because you're in Canada, so they will be doing a more cosmetic surgery. Okay. And with robotic surgery, less bleeding. So there are advantages of it. And you have to think about your fibroids would be different from her fibroids in terms of location and size. So it all has to do with the individual patient. But yes, you do robotic surgeries for fibroids and other gynecological surgeries. Yeah, it's a new thing that has been advancing in the past 2 years now.
Thank you.
You're welcome.
You're welcome,
as we move
Kay.
on, is there generally less information on fibroids than other conditions like endometriosis?
To be quite honest, I think endometriosis has less information out there. But with all gynae conditions, I think we're lacking as women that it's only now in the past 10 years that persons are now trying to do research, trying to play catch up, more attention to gynecological conditions. As I said before, in Leeds, we have an endometriosis trial, which is a national trial that different tertiary centers doing as well. And it's looking at what causes endometriosis, as well as should we remove every endometriosis that we see in the body, because some endometriosis tissue go to the lungs, they go to the liver. Yeah. So a lot of work now is being pumped into gynae health or women's health. So yes, we lack information, but we're getting better.
Yeah, I can also agree with you there, Doc. From my journey, having I was diagnosed in 2006. So we are almost 20 years later. And so I know what kind of information I found 20 years ago to where we are today in terms of more information coming forward. And it's still not as prevalent as other issues, although the numbers are staggering. That's a whole other conversation, I think, about women and medicine, but that's another time, right? So as we move along, another question here from Ms. Eastman. Is it true that birth control administered over a long period of time to manage periods can lead to infertility and increase the risk of fibroids?
I disagree with that statement, or that question, sorry. So just to answer the question, long-term use of contraceptives. So it depends. So it said pills, right? So normally when you stop pills, it takes a while for you to actually get back in terms of trying to conceive. It can take a while, not like the Mirena coil. When you insert the Mirena, in terms of like you can get pregnant again in next month. Sometimes pills can take a long while, but then it's the same thing, the same workup. Is it just being on a contraceptive for a long period of time that is making your period not come or making you not conceive? Or if it's something else, it's hormonal, is it age, is multiple factors. So I wouldn't say that being on a contraceptive pill would reduce your chance, and then stopping would then reduce your chance of having a baby.
And what about increasing the development of fibroids from birth control?
What about what? Decreasing?
The increasing of fibroids developing because
increasing
of birth
fibroids,
control.
No. Remember, it's something else. It's estrogen dominance. So no, it wouldn't increase the fibroids.
All right. Thank you so much for that response, Doc. Vitamins to consume in terms of health, or you want to leave that for our nutritionist next week?
I can tell you what I take. I take vitamins.
Yeah.
So to be quite honest, well, I'm in the UK, so obviously vitamin D, lack of sun, but you all have sunshine in Trinidad and Tobago. God bless you all. And certain things like you want to take your biotin, you want to take because now as we increase in age, you want to take your collagen, like, because you want to think about your skin, your inside, you want to, zinc. So any multivitamin, women health, that's good. Any multivitamin for women, that's good because it has each of those things in it.
All right, thank you for that. And for the person who asked about vitamins, be sure to join us on the 14th as we talk about food as medicine, fibroids and nutrition. All right. One more question before we go, Doc. What's the best advice for someone who has PCOS, experienced miscarriage and infancy loss, and then a successful pregnancy, right? So that was their history. Then there was a successful pregnancy, but now 7 years after, there's seemingly recurrent PCOS and now fibroids. What's the best advice for a way forward?
So I will ask them, what is the age? Because it all has to do with the age, because as we get older as women, our fertility rates decrease. But once you pass 35, you know that your fertility rates reduce, unfortunately. So I'll first ask the question, like, what is your age, right? Because you increase the chances of it's getting harder to get pregnant once you're over 35 or when you enter 40. So that's one, right? And yes, race and recurrent PCOS, but we have to think about in terms of the entire situation, like with polycystic ovary syndrome. Are you of high BMI? Do you have a bit of tummy fat? Because it all has to do with diet and exercise. Because with PCOS, you want to have regular periods. So PCOS is preventing you from, and preventing someone from having regular periods. And to get pregnant, you need regular periods.
Right. And then the fibroid, now it will depend on where it is.
Depend on the size, location, everything. So that's a wonderful question, Makeda.
Okay, so in terms of the best advice or the way forward is really just having the full picture painted, understanding, particularly with the fibroids, what's its location, your age, what your plans are, and essentially mapping now a plan towards, I guess, pregnancy, if there's PCOS, treating with that, and the fibroids as well.
Yes.
Okay. All right, I hope that question I hope we kind of answer the question. Oh, she's saying 36. So you're just outside of the medical one here, but you just enter the race, quote unquote, to things slowing down, 36. Right? So there's still much hope there. But
there's so much hope.
Yes, you have to look at PCOS, your PCOS circumstance, and as well as the fibroids, and then you have to plan. I think you have to plan what the steps are in terms of treatment and working towards a pregnancy. And Doc?
Yes, I agree. And I just have to pause and say, very important, have a gynecologist, get your pap smears done, your smear test done. Very important. Because we could talk all we want about fibroids and wanting to get pregnant, but cervical cancer is on the rise and you need your smear test, you need your pap smears.
Thank you so much, Doc. So, ladies, it is 6:38 p.m. I think
that's
we are
11:38 p.m.
Yes, I really want to thank you, Doc, because you are in the UK, you are 5 hours ahead, and you have taken precious time, right, on your day off to share with us when you should be resting to get ready for work tomorrow.
I don't have work tomorrow.
Oh, thank God. That's okay then. But we still want to thank you because you're cutting into your night rest to share with us here at home. And we are absolutely grateful. I also want to thank everyone for coming online with us. I think we peaked maybe at about 28 or 29 persons online, which is awesome, right? It's our first session back, Fibroid Awareness Month 2025. And we are truly grateful for your, coming and sharing openly. It's really about information, empowerment, and encouragement. That is what it's about. I've recently been saying, the first step towards change is awareness. If you do not know, then you won't be able to make the best decisions. All right. I am not a medical person, so I always do the disclaimers and I try to ensure that we do have the professionals in the room so that we can have the questions answered and we can guide you accordingly. But anything that we've shared here this evening, of course, you have to revert to your trusted practitioner, get to your gynecologist, and always seek, just multiple opinions from the experts, of course, as it relates to you. And finally, I want to say, your body. You know your body, you know how you feel, you know when something isn't right. Listen to your body, take care of it. It's the only place we really have that we live in, right? That is really ours. So be encouraged, ladies. Thank you so much. Doc, anything else you want to add before we wrap up?
First of all, I just want to apologize for the late start of things. That was particularly my fault, and not knowing Zoom again. Last 5 years of doing it. I do apologize. I logged in at 15 minutes before. Sorry for that. But thanks again, Corey, and thanks again for everyone for listening. I'm very passionate about women's health. So any talk you want me to do, endometriosis, polycystic ovarian syndrome, anything, adenomyosis, anything, I'm very happy to share information, because I do believe that, one, we know our bodies as women. Two, we need information. We need to understand what's going on. We need to know how to seek help and what help is available to us. So thanks again,
Yes,
everyone,
agreed.
and God
You
bless.
are welcome. Yes, and as it relates to other issues of the uterus, while we are Fibroid Awareness Trinidad and Tobago, just as we have done in the past, our information and our sessions won't only be about fibroids, but they would be about other issues of the uterus. And of course, ladies, we ask you to, follow us on our socials, share the information. We have our session on the 14th, fibroids and nutrition. We have our general session. This one is face-to-face at the Scarborough Library on the 22nd of July. That's with Dr. Chantel Winchester Sampson, Dr. Wynn. Next week's session is with Miss Melissa Agbeko Walker. She is a health and wellness coach. And then, of course, to end this month of activities, you can find us in Black Rock at Optimal Health Services Limited, which is Dr. Alimayu Chadban's space where his practice is. We are having our first free clinic, free ultrasounds, free consultations. So find us, visit our website, register. As you might imagine, the free ultrasounds, they won't be unlimited. So you have to definitely get in early, fill out the form so that you can be assessed. And once you are confirmed, you will know whether you've been able to get one of the free ultrasounds on that day. And stay connected. We are also available to do presentations in schools, communities, churches, you name it, in Trinidad and Tobago. Yes, I'm from Tobago. Yes, I'm based in Tobago, but it is Fibroid Awareness T&T, and we are ready and available to do what is needed and to continue to provide the support as we have done to women in Trinidad, in Tobago, and in some instances, even up the region. I want to thank Colette. She's from Jamaica. I saw her come in this evening, so I want to thank her for that. Yeah, so that's it, ladies. Have a wonderful, and yes, we'll connect with Canada as well. Yes, we will. Once you call, we will answer, because this is definitely divine instruction, and we continue to do the work. So have a good evening, everyone. And the phone number was shared in the chat. Let me also put the email so that you can contact us via email. And then, of course, you can also follow our website, www.ttconfidenceproject.org. That really is about our outreach, but of course, you'll get all information there. And you can also register to volunteer with us, of course, because we need persons to help us when we have different events and activities and even sessions like these. All right, so it has been a pleasure. You're welcome, Jamila. Ladies, have a great evening. Thank you, and bye-bye.
Thank you. Bye.
Thank you.
Bye-bye.
Bye.